Should individuals diagnosed with MGUS or smoldering myeloma be receiving bisphosphonates?
There are many studies on MGUS or smoldering multiple myeloma patients and the role of bisphosphonates. So far, all the studies showed that bisphosphonates should not be given in patients with MGUS or with smoldering multiple myeloma. You cannot really prevent the progression of multiple myeloma when you have smoldering multiple myeloma and you treat it with bisphosphonates. Usually when patients come to my office and ask me, I have bone loss, should I get bisphosphonates? My endocrinologist is recommending me this. I recommend those patients that they should receive bisphosphonates according to the guidelines of endocrinology for bone loss. For instance, that they should receive bisphosphonates only a year. I would only start treatment with bisphosphonates in a monthly fashion, like we do it for multiple myeloma, when patients have overt multiple myeloma. So that means only patients with active multiple myeloma should receive bisphosphonate treatment for at most 2 years.
Patients with MGUS, as I mentioned earlier, have a much higher risk for fracture, somewhere around anywhere from 1.5 for a hip fracture up to about 6-fold higher for a vertebral fracture. So in general, I tend to have a very low threshold for providing those patients with the bisphosphonate. I would like to get a bone density scan done first, which we typically do to evaluate for osteoporosis, but then recognizing that whatever that score is by bone density, they likely have additional bone loss that's not been recognized. And the reason for that is a little bit complicated, but basically a bone density is a two-dimensional imaging of the amount of bone that's there. Obviously, we know bone is not a two-dimensional structure. Bone is a three-dimensional structure. And the bone density scan basically just can't differentiate that, what we call the trabecular bone, which is the inside part of the bone, from the outside part of the bone, which is called the cortical bone. And it can't sort of provide the specific understanding of the changes in bone microstructure that are there. So it's just not a very sensitive technique. So if patients with MGUS have osteoporosis by bone density scanning, well, then they should definitely be treated like a standard osteoporosis patient, which is typically to treat them with a bisphosphonate or other anti-resorptive therapy. If they have normal bone density, well, then they probably don't need to be treated. The gray zone becomes if they're in the osteopenic range by bone density testing, because those patients with osteopenia are at a higher risk for fracture than with normal, not as high as with osteoporosis. But I personally consider medications like bisphosphonates to be very safe. I have a low threshold for starting patients with MGUS and osteopenia on a bisphosphonate. Typically recommend doses which are consistent with osteoporosis. So a medication like alendronate, which is generic Fosamax, 70 milligrams once a week for about 5 years. Alternatively, if patients can't tolerate that, then we'd consider intravenous zoledronic acid or Reclast, which is a once-a-year IV medication, typically for about 3 years. I also counsel my patients that there are many other aspects of bone health besides pharmacologic agents. So the first thing that I counsel my patients on with MGUS is the importance of limiting the risk for having a fall. Their single greatest risk of having a broken bone is having a fall. The second thing is limit their lifting. And if they're going to lift, do so with their straight back, trying to bend their knees so that they don't put excess pressure on their spine. The third thing is to stay as active as possible. So I'd like patients to walk or other weight-bearing activities for at least an hour in total daily. It can be 5 or 10 minutes at a time, but they can't spend their day being a couch potato. And the last thing is to ensure that they get enough calcium and vitamin D. Intake typically about 1,000 international units of vitamin D, and for most patients, somewhere between about 1,000 and 1,200 milligrams of calcium. That calcium can come from other food sources or it can come from calcium supplements, but over the course of a day, it needs to add up basically to about the numbers I just mentioned. Patients with smoldering multiple myeloma are at a much higher risk for progression to multiple myeloma, but they're also, we think, based upon some preliminary data we have, at a higher risk for having a fracture. Like patients with MGUS, I have a very low threshold for treating with a medication to limit the risk for bone loss. Typically, if a patient has smoldering multiple myeloma, I would obtain a bone density scan. If there's any evidence for any fractures, I think that patient would warrant a bisphosphonate therapy. That could be either in the form of zoledronic acid or Zometa or Reclast, provided once a year for at least 3 years, or alternatively alendronate 70 milligrams once a week, provided for at least 5 years. They should also be counseled on the importance of limiting the risk for falls, limiting their lifting, using a straight back when doing so, maintaining an active lifestyle to include activities like skeletal loading, such as walking, or other weight-bearing activities for at least an hour in total daily, and maintaining adequate calcium and vitamin D intake. Vitamin D intake should typically be about 1,000 international units a day, and calcium typically between about 1,000 and maybe 1,200 milligrams a day.